Good morning, my friends. I'm sharing an experience with you where I lost a patient a few months ago. This was a 64-year-old farmer who had come to me a year earlier for a few episodes of syncope. His evaluation established a diagnosis of CCTGA with mild ventricular dysfunction and some degree of left AV valve regurgitation. His Holter showed complete heart block intermittently. So he was put on sacubital valsartan and he was recommended CRT-D, which he refused. He said he's doing well and he can't afford the cost anyway. It took another few episodes of syncope and 6 months before he came back to me and consented for a VVI pacemaker. He didn't have it. He arrested and died in the cath lab when the venous access was being secured. The average lifespan of a Keralite at birth is 72 years. This gentleman died at 64 years. Was there a way in which I could have added this 8 years or more to him? Would be a thought that would be in the back of my mind when I see a month-old baby with CCTGA. The patient with CCTGA and no symptoms is not a single anatomic entity. Indeed, there is a spectrum there where the dominant entity, of course, is no structural lesion and normal sinus rhythm, but you could have minor structural lesions, no structural lesions, and a complete heart block, some degree of left AV valve regurgitation or systemic ventricular dysfunction, or even the entity of the major problem, large VSD and moderate pulmonary stenosis, but with a saturation above 90%. Do we have a rationale for intervening in these patients? When we look at literature, there is a University of Alabama data presented recently in which 9 out of the 31 cases had no major lesion. And at the end of 10 years, they did well, but for one patient who died a few months after enrollment. The operated patients had their share of mortality, RV dysfunction, and the freedom for survival without RV dysfunction was only 68%. This type of experience is in support of our inferential conclusion that CCTGA, in the absence of major associated cardiac lesions, would remain asymptomatic for a long, long time. And this is the benchmark that should be there when you are offering intervention to these patients. And when you look at long-term outcome in other studies, in one of the largest multi-center studies published 20 years ago, those without any major lesion, there was a 75% chance of reaching up to the age of 45 without any major problem or heart failure. And why does systemic ventricular dysfunction occur? Because the RV is not suited for this purpose. And we hope that one day we would unravel the genetic mechanisms underlying the adaptive capability of the systemic RV and be able to modify it. If it is not an asymptomatic patient, if you have a large VSD, LV outflow obstruction or AV valve regurgitation, we have a variety of options with variable degrees of physiologic, with degrees of complexity and risk between the various options. How did we start thinking about anatomic repair at all? This is because of spectacular success of cardiac surgery brought to this country by Dr. Rajesh Sharma and others, where extensive experience with Senning and Mustard, excellent surgical results with arterial switch, and pioneering results with training the left ventricle and doing a switch. That was pioneered by Roger Mee in his initial paper itself. There was excellent results for double switch and also for arterial switch following PA banding, and their intermediate term results were good. So the French thought, why not extend this to the CCTGA intact ventricular septum and no major issues. And they offered prophylactic PA banding to 11 asymptomatic babies and did a double switch in one of them 7 years later when the ventricular pressure had become suprasystemic. Otherwise, their idea was just to keep the ventricle in such a way that the septum is in the midline. And they felt that this was a smart thing to do. The Chinese thought you don't need to go too far, but ban the PA alone. And the Boston Children's Group, extending the concept of training the left ventricle, looked at the data and found that in their 25 patients and 18 patients having double switch, LV dysfunction developed in the ones who had it after 2 years. When you did a PA band and double switch, after 4 years, there was a greater chance of LV dysfunction. Mind you, 9 of their patients had no major lesions, and therefore they concluded that this is a good thing to do, and the earlier you do it, the better. And they built a case for early anatomic repair, said that you should band and choose for arterial switch based on their further progression. And this seems to be the best thing to do. However, there is no robust data to support that for the CCTGA, no structural lesion, normal systemic ventricular function, band, and if necessary, do a switch, they will do well. The actual results do not speak like that. And when you look at the Cleveland Clinic data, the pioneering data in the field, over the long term, you find that anatomic repair patients had only an 80% survival, only a 10% better than those with physiologic repair. And the Toronto experience was a little more depressing in that 20-year survival is 53.6% inferior to that in the physiologic repair group, which compelled this editorial from JTCVS by Twiddle, in which he felt that for those with a tricuspid valve regurgitation or RV dysfunction and LV already working at systemic pressure, it means there is a large VSD and an outflow obstruction. Anatomic repair is a good thing. In the remaining patient where you actually need to prepare it, he felt that maybe physiologic repair is not a bad thing to do. And he was not impressed with the role of LV retraining. So at the end of this discussion, what people have concluded is that there is no great data supporting offering surgery to the real asymptomatic patient with CCTGA. And you need to choose the patients. And when you have seen the long-term results in the best centers, be it Cleveland or be it Toronto or the Japanese data, the data is not robust enough to support intervention for the asymptomatic patient with no lesion. And therefore, what would we do for the asymptomatic patient with CCTGA? If there is no structural lesion, normal sinus rhythm, minor structural lesion, like mild PS, small VSD, mild left AV valve regurgitation, I do not find any data to send them to the surgeon. I would leave them alone, certainly follow them up. And if there is no structural lesion and complete heart block, then of course, it's a different story. We would consider permanent pacemaker implantation as per guidelines. The little tricky issues would come when there is a moderate left AV valve regurgitation or mild systemic ventricular dysfunction. What could we do? If they are young, if they are below 15 years, going by Roger Mees criteria, they could have a PA band and you could evaluate them for a double switch. But if they are older, this option certainly does not exist. You could still consider them for PA banding. Perhaps in a given patient, it might centralize the septum and improve their tricuspid regurgitation. But in the majority, you would need to follow up tricuspid regurgitation in the long run and offer tricuspid valve replacement when indicated, for knowing the limitations of this. But this knowledge is not compelling me to offer surgery to the asymptomatic CCTGA with no structural lesion. And I would also say the one with the VSD, PS and a saturation more than 90%, I would follow them up. I wouldn't necessarily offer double switch to them. But if their saturations are in the 80 to 85 range, I would offer a Senning-Rasteli versus LVPA conduit to them, and even consider Fontan, as has been elegantly discussed by Tom Carr. Thank you very much.
Thank you, Dr. Suresh. Yeah, it is not uncommon to encounter these patients in 5th decade or 6th decade. The survival may be up to even 8th decade or 9th decade, but they are all occasional, rare encounters. We have with us Rajesh Sharma, who is the proponent of anatomical repair for these patients with CCTGA, whose publications everybody knows. His the European Journal publication, his JTCVS publication in 2009, everybody would have read, who shows excellent results with this double switch operation, especially the atrial switch plus the arterial switch. And he has shown that even after a when the morphological left ventricle is in the systemic circulation after the arterial switch and the atrial switch, patient continues to have, in some patients, the continuing progressive systemic ventricle dysfunction. Rajesh Sharma is known to everybody here. Everybody would have read this paper. So Rajesh Sharma, please.
Thank you, sir. Hi, Suresh. We are before the tea break, but let's have tea anyways. It's the kettle is boiling, and let's sit down and have a chai ki charcha. So the problem with this CCTGA is that you have limited windows. I would agree to following them up, if they are asymptomatic, if there's nothing, but how do you predict that they are going to remain the same and there is not going to be a lesion, because lesions develop, which is left atrial regurgitation as the right ventricle fails, and the window does not remain open forever. So just let's go over some of the slides. So if you see this video, this is CCTGA, intact ventricular septum, the situs inversus. What is the two questions that arise in your mind? What is the age of the patient? And does he have left AV valve regurgitation or tricuspid regurgitation? We have a color Doppler and it shows us he has significant tricuspid regurgitation, bowing the septum to the other side. And now the question arises, what is his age? This once again shows severe tricuspid regurgitation. Now age is all important. So asymptomatic CCTGA can be found in these subgroups as you have already described. It could be intact ventricular septum with or without tricuspid regurgitation. It could be intact ventricular septum, restrictive VSD with left ventricular outflow tract obstruction, isolated. It could be CCTGA VSD-PS with the balanced QPQS where clinical cyanosis is mild and saturation is 85 plus 90, 92, and you say, okay, fine, let's leave him alone. Or it could be unoperated CCTGA VSD-PH who comes to you when he's already Eisenmenger, he's become asymptomatic, he's just balanced at that point in time that he's not started to turn very blue. So he's asymptomatic. So let's just deal with these group of categories. Now that group without with the intact ventricular septum and with or without TR. Now it is a fact, as you stated, that the left ventricle can be prepared only before the teenage years start. There is no guarantee that TR will not develop anytime down the road. And once TR develops, we know that the course is rapidly downhill. And at that time, the treatment is medical. He's too good at present symptomatically to require anything. So let's just start enalapril, Lasix, this, that. And then finally, when the ventricle starts going down, we start considering tricuspid valve replacement. We know the ventricle will get worse with tricuspid valve replacement. Repair is out of question, it does not work. So let us just wait. He's too good for a transplant. Let's just follow him up with some medicines. And then finally send him to the transplant surgeon who says he's not that bad, some increased diuretics. Let's him for transplant. Ultimately, he does not get a transplant in time. So this is the general accepted time management of CCTGA, presenting initially with no lesion. And you will agree that the precious window to prepare the LV will get lost as soon as this guy crosses over into the teenage group, and the left ventricle is eminently preparable if it is done in time early in life. All this data is dependent, this reluctance to prepare the left ventricle is dependent on certain studies which you quoted, And one of these is from Birmingham, and they report that there is a 20% failure rate of the left ventricle as time passes in the patients who had required LV preparation. However, this is in variance with our own data. And in our data, we found that people who were prepared, children who underwent left ventricular preparation before 14 years of age, started off with a lower LV function, lower ejection fraction initially, which gradually increased up to 50 to 60%. And this is the normal LVEF we have realized that does exist in the post double switch patient after going anatomical repair in any of the three categories with PS, with VSD, unband after preparation of the ventricle in the intact ventricular septum group. And the best saturated the LVEF you get is generally 50 to 55, sometimes 60, and we accept it as normal in this group. And we have attained this in our prepared left ventricle LV prepared by banding group, which is pretty good results compared to many of the other centers. The same paper from Boston Children also favors that if it's done early, you can get good results with this operation with good left ventricular functions if it is done in time. In the sub-PS group, which is isolated sub-PS, this group also exists in CTGA with or without a restrictive VSD. Now, initially the PS is dynamic, it's mobile, it's pliable. As time passes, that same obstruction, you will find people coming in their 20s and 25, 30 years of age. It is calcified, it is cartilaginous, and that same LVOT obstruction is unresectable. Hence, there is nothing to do but just to say that the left ventricle, can tolerate a high pressure. Let's hope that the left ventricle doesn't allow the pressure of the septum to be pushed in the other direction. Let's hope the RV remains good and hopeful management till life continues. There is a third group, which is CCTGA VSDPS, which you mentioned, which is balanced QPQS, where clinical cyanosis is mild. And some of these patients, if you look into that, have dynamic LVOTO and may actually be amenable to the switch sending option if it is done early in life. So I would not say that you just leave them alone without looking at their echoes. Some of them can undergo surgery without the use of a conduit, and that is a good thing to do if they have a resectable or a mobile LVOTO, mobile morphology calling LVOTO. There are others who will develop cyanosis, aggravation of cyanosis, and become symptomatic. This PS is not going to remain the same. Unfortunately, human life is long. It continues till 50 years, 60 years, 70 years, and the cyanosis is not going to remain what it is 90 today. It is going to worsen with time. And these people, as soon as they lose their sinus rhythm, they go into atrial fibrillation. As they develop left atrial regurgitation, they become symptomatic, and then they come to you. And when we operate them, it is not easy. It is like, I don't know whether this guy is going to come out of bypass without the use of ECMO, because the ventricle is so thick that when you cut into a ventricle which is 2 centimeters thick and you're trying to close that VSD through that ventricle, you do not know how this ventricle is going to behave post-operatively. So this was once upon a time a patient who was asymptomatic, 90% SATs. He had good anatomy. He did not have thick ventricles. They were amenable to myocardial protection, good anatomical repair. He could have been operated in the first decade of life. We left him alone, get married. Okay, now the time comes to have children. Okay, there's some cyanosis. The gynecologist says cyanosis can, cause loss of pregnancy. So let's do the repair. She's already 25, 30 years old. And then the poor surgeon has got a 2-3 centimeter thick ventricle to handle. Married girl, I don't know whether I can get her out alive. So we had this case she's a pathologist and she came to us 5th decade of life, asymptomatic. At that time, when she was in her 20s, the operation had just started. And at 50 years of age, she developed atrial fibrillation, went on all sorts of medicines. She says, I can't take a lecture without getting breathless. So she wanted to get her operation, and luckily we got her out in good shape. And we wrote in the comments, and it's worth reading this, the Restelli, and I'll just read it out. The Restelli sending operation involves long intraoperative support times and multiple redirections of bloodstream with multiple potential sites of residual problems. Hence, it is not surprising that even today, when anatomical repair for CCTGA with or without its association is established, there is a reluctance among the cardiology fraternity in referring a patient for such an operation, especially if a patient has balanced pulmonary and systemic blood flows and is relatively asymptomatic. It is also true that we do not have truly long-term results in these operated patients of 20, 30 years follow-up, because this operation itself came in only in 1991 and is even now it is controversial because results between centers are so variable. Some centers say it has excellent results and other centers say it has worse results than conventional repair. So what do? So you manage conservatively, and then you send the poor patient with a very thick ventricle to the surgeon, to the poor surgeon. So that's the problem. There is one category of patients of CCTGA, I would definitely agree with Dr. Suresh, and that is with who have large VSD, who have already developed irreversible pulmonary vascular disease. Thank you, sir.